Thank you very much for inviting me. So I'm going to talk about prosthetic valve thrombosis, focus on imaging. First we'll talk about some clinical features. So the first prosthetic valves were implanted in 1952, and this is the first series. They found out of the first 100 patients, 17 died. And 8 of those died due to low cardiac output, and the majority were due to thrombus on the valve or cerebral emboli. And this is where we first recognized valve thrombosis occurs in prosthetic valves. And if you think about why thrombus occurs, it's different on each valve, and this relates to fluid dynamics. So here we have 3 different valves: ball and cage, tilting disc, and bileaflet. And if you look at the flow in each one, it's very different. So in the ball and cage, the lowest flow is at the center of the valve, whilst in the tilting disc, it's in the minor orifice, and on the bileaflet, it's on both sides where the sewing ring is. And that's where you're most likely to develop thrombus. So if we think about why thrombus develops, apart from flow, there are hemodynamic factors such as low cardiac output. That's why it's more common on right-sided valves if you've got mechanical tricuspid valve disease. Hemostatic factors such as hypercoagulable states, such as antiphospholipid syndrome, and then incomplete endothelialization. So there are 3 main causes. What's the incidence of valve thrombosis? Well, these are large series looked at incidence rates. First, you see in the yellow arrows that mitral valve has much 5-fold incidence of valve thrombosis compared to aortic valve, at 0.5 per 100 patient years. And ball and cage have a much higher risk of thrombosis compared to tilting disc or bileaflet. And then we move on to anticoagulation and identifying where the optimal rate of anticoagulation is. This looks at stroke risk versus hemorrhage risk. So if you look at this graph, you see stroke risk reduces as your INR increases. And then if you look at the dotted line, that's where hemorrhagic or hemorrhage increases as your INR increases. So this is the sweet spot where you've got the lowest rate of ischemic stroke and bleed-in, and that's an INR of between 3 and 4. And you see the same on the bottom, at INR 3 to 4 is where you have the lowest ischemic stroke, but also the lowest risk of bleeding. And that's why most of our data on what the optimal INR to prevent thrombus is. But not only is it the INR level, it's also the quality of anticoagulation. So this looks at time in therapeutic range. And in the yellow box, you see time in therapeutic range above 70% and below 70%. And you look at the risk of bleeding, your risk of bleeding doubles if your time in therapeutic range is less than 70%. So it's not only the optimal anticoagulation, it's not in the level of anticoagulation, but also the time in therapeutic range. And self-controlled anticoagulation is better than our traditional warfarin clinics. This is a randomized study looking at self-anticoagulation as opposed to having anticoagulation checked in hospital. And if you look at the time in therapeutic range, we see on those who are self-managed anticoagulation is much higher than those who have their anticoagulation managed by hospital. So that's a bit of background to valve thrombosis. Moving on to imaging, which I think was the main part of the talk, we can either have non-obstructive thrombus, which is asymptomatic, often picked up on routine imaging. For example, if a patient with a mechanical valve has an embolic event, you might pick that up. Or obstructive thrombus, which is reduced cardiac output, heart failure, and insidious dyspnea. And let's go through the imaging features to work out what are the most useful. So the first thing you'll notice is gradients. But the problem with gradients is this looks at normal patients with prosthetic mismatch in the pink, and people with occluded valves in the green. It's difficult to identify, if you've not got prior data, whether the high gradient is due to occlusion or stenosis of the valve or patient prosthetic mismatch. The gradient is the first clue. And then we can use other features such as acceleration time and ejection time. So acceleration time we can measure quite nicely on a simple Doppler from the start of ejection to peak, and we can measure the ejection time of the whole Doppler trace. And with that, this helps us differentiate, because acceleration time, as you see here, if you have controls, those are patient prosthetic mismatch, and those with a stenotic or occluded valve, whatever the cause, is higher. And if you have acceleration time over 100, that suggests there's going to be valve obstruction, but there's an overlap with patient prosthetic mismatch. But when you use a ratio of acceleration time to ejection time, we can see that if your acceleration over ejection time is more than 0.45, it helps you differentiate between mismatch and normal patients. So it's acceleration, it's your increased gradient, increased acceleration time, and acceleration over ejection time of more than 0.45. Then we can move on to our color flow. So if you have an obstructed valve, it's pathological regurgitation. It tends to be central or eccentric, as you see in this video here. And you'll see the absence of color flow through the obstructed area. So you've got color on the disc which is opening, and the disc which is occluded, there's no color flow. You see it nicely on the 3D at the bottom, where on the 3D color, there's no flow through that leaflet. And we tend to see a soft tissue mass, but it can be difficult. Acoustic shadowing can limit our views. Obviously, you see a fixed disc leaflet here on the TOE, but it's important to use both TOE and transthoracic. So on the same patient where we can't see the clot on the TOE, we performed a transthoracic, and there you can clearly see the thrombus causing that occluded disc. So it's a combination of transthoracic and TOE. And just another example where you can see the clot on the occluded disc, and we see the absence of color flow through that area. So we've looked at the disc, we've looked for thrombus, we've looked at the hemodynamic parameters. Does thrombus size matter? Does it matter the size of the clot? This looks at the area of the thrombus and complications. As you can see, if you have a small thrombus, so less than 0.8 centimeters, the risk of complications or mortality is relatively low. It's still there, but it's relatively low. But as your thrombus size increases, the risk of complications increases and death. And this will be important when we come to talk about whether you're going to perform surgery or thrombolysis a bit later on. If you can't see it on transthoracic, then CT is a very good alternative modality. And here you can see a clot on a mechanical valve, which wasn't seen on the transesophageal echocardiogram. And on CT, we can look at the attenuation to help identify whether there's thrombus or attenuation. So here you have pannus. You see the Hounsfield units of pannus are much higher than those of thrombus. And a Hounsfield unit of more than 145 is good to differentiate between pannus or thrombus. So CT is very useful in that respect. So we can put all this together to create a diagnostic algorithm. So we have our patient with suspected valve thrombosis. We can use transthoracic, looking at the valve gradients, acceleration time, ejection time, looking at the leaflet mobility and thickness, and looking for soft tissue masses. We can then move on to transesophageal to look at things in more detail, and often we can look at thrombus size, which is important. And then we can differentiate between obstructive and non-obstructive thrombus, where you need to optimize anticoagulation, and obstructive thrombus, where we need to consider valve thrombolysis or surgery. But often it's not clear. Sometimes there are high gradients, but you can't see valve motion clearly. And in that case, CT or fluoroscopy is either very useful to look for the motion or pannus on CT. So let's look at some cases. Here's a 52-year-old who had a mitral valve replacement 8 years ago and had a TIA, so transient ischemic attack, and some chest pain with a mildly elevated troponin. And on CMR, there was a very localized inferior infarct. So we performed an echo just to check their prosthetic valve was okay. And the gradient was just a little bit high, 6. And the INR was therapeutic, 3.2. So this is the TOE. And we can see that the discs actually open normally. But what we do see, there's a little small thrombus attached to the sewing ring, causing increased gradient. And it's likely the cause of their embolic infarct we saw in the CMR. So this is just 3D, where you can see the clot on the 3D, and we can see elevated gradients of 6. So in this particular patient, we have non-obstructive thrombus. The NYHA1, they're seen in outpatients, the grade is slightly high. We know they've had embolic infarct due to this clot. So we optimize the anticoagulation, increase the INR range from 3 to 4 to 3.5 to 4.5. Repeated imaging, thrombus was still there. Added some antiplatelets. So in this case, we added aspirin, or you could add clopidogrel. And the end result is, after that, the thrombus had resolved. The gradient had gone down, as you can see quite nicely on this, on the TOE here. So that's non-obstructive thrombus, which we've treated with anticoagulation and antiplatelet. The patient had an infarct related to thrombus. So let's move on to obstructive thrombus. So here's a 67-year-old, had a mitral valve replacement 10 years ago, has a history of depression and stopped the anticoagulation a few weeks ago due to a family event. And they came into hospital with shortness of breath, drowsy, slightly hypertensive, so blood pressure 98/47. This is their transthoracic echo. And the first thing you see from the transthoracic echo is, obviously they have LV impairment. The most striking feature is the RV is severely dilated, and the RV is dyskinetic. And as well as the RV being dyskinetic and dilated, we can't see any motion of the valve discs. So this is the first sign of a problem with the dyskinetic RV, and we can't see motion of valve discs. We can put the color flow on, and we see there's a problem straight away with the flow through that valve and flow acceleration. Gradient is almost 3 meters per second, or 2.5 meters per second. So there's a suspicion of valve thrombosis. Here's the TOE, and we can see actually there's clot in the whole of the left atrium. This is enormous clot filling the whole of the left atrium, going in and out of the valve, and one disc is completely occluded. We see the 3D, and here we can see the clot in the left atrium going in and out of the valve disc. So this is a very large thrombus. So this patient's NYHA4 in RV impairment. In this case, cardiac shock, and they have urgent redo surgery. So when do we use surgery, and when do we use thrombolysis? This is the largest study I could find from old-style thrombolysis, 110 patients from France and the US. And the first thing you notice, success occurred in 70% of patients they thrombolized. So a third of patients, thrombolysis was not successful. In addition to that, complications occurred in 25% of patients with thrombolysis, mainly systemic embolism. So primary thrombolysis, A, is not effective in a third of patients, and B, in about 20 to 30% of patients, causes embolic events or stroke, so it's quite high risk. And this is replicated in many studies. This was just a review paper where it looked at surgery and thrombolysis, and you see that thrombolysis success rate in the green is anything from about 60%, well, 50% up to 70, 80%. So anything from a third to half of patients doesn't work. And when you look at major embolism, you see it's anything from 10 to 30%. So is there a better way to do thrombolysis? So the old ways were the rapid thrombolysis over an hour to 2 hours. But now we've got slow, low-dose thrombolysis. And this looks at the outcome of different thrombolysis regimes. So you've got group 1 and 2, which are the old style sort of 1 hour, 2 hour thrombolysis. And group 3, 4, and 5 are the slow, low-dose thrombolysis. And what you see is over time, the success rate has increased in the green with slow thrombolysis, and the complication has significantly reduced. So complication rate of 40%, we're now down to sort of 5 or 10%. So this is one of the seminal papers which looked at slow, low-dose thrombolysis. This was in JACC a couple of years ago. And this is the protocol. Now, it looks complicated, but actually, when you look at it in detail, it's actually quite straightforward. So here you have your patient with obstructive valve thrombosis. In cardiac shock, they went for immediate surgery. If you're in sort of functional class 1 or 2, you had TPA over 25 hours. You reassess the gradient with transthoracic echo. If there was success, that's all good. If there was still obstruction, you repeat the TPA over 24 hours and then reevaluated by transthoracic. And if you had a reduction in gradient, you do a TOE to check the thrombus is resolved. And you can do that up to 3 times. And if you're NYHA functional class 3 to 4, they gave it over 6 hours and then reevaluated up to 3 times. And when they looked at the outcomes of this, it was quite remarkable, actually. So if you look at thrombolysis versus surgery, the embolic events, previously they'd reported 30-40% risk of stroke and embolic events with thrombolysis. Here, with low-dose, slow thrombolysis done in this way, just 2% embolic complications compared to surgery of 5%. And 3-month mortality was just 2% compared to 18% on surgery. That's just a graphical representation of the outcomes of slow low-dose thrombolysis versus surgery. You can see the complications of mortality are lower with this technique. So here we have a case where we used that. So 69-year-old mitral valve replacement. This person actually stopped anticoagulation due to compliance a few weeks before, admitted in heart failure. This is their transthoracic echocardiogram. So immediately you can see from the 4-chamber view, the discs of the valve are stuck, they're not open and closing. We can see the RV is dilated with impaired function. We see there's no color flow through the occluded discs. And we see a high gradient, this time of 8. We do a TOE. We can see one disc is fixed. We can see clot where that disc is. It's a relatively small clot, so I'd say it fits in about sort of less than 1 centimeter squared. We can see the lack of color flow, which we talked about during that area. And we can see it nicely on 3D, the fixed disc. So this particular patient was high risk for redo surgery, but also they had a very small thrombus, but were in heart failure, pulmonary edema. So we decided to use this slow low-dose technique. So we gave 25 milligrams TPA over 24 hours. We reassessed everything, no change, patient still in pulmonary edema, but getting slowly better, repeated it, and then the gradient after the next thrombolysis was 1.5. And here you can see on the transthoracic, now the valve discs are opening, color flow is normal, and the gradient's low. So that was a successful low-dose thrombolysis. And we repeated the TOE. Once we've done that to check the clot had resolved, you see the discs are moving, clot had all resolved, color flow normal. We can see it on our sort of a 3D view as well. So if we summarize what we've just discussed, we have valve thrombosis, we have non-obstructive, asymptomatic patient, maybe embolic, mechanical valve. If the INR is subtherapeutic, we give IV heparin until INR therapeutic, or we can increase the levels, the case we did before, or plus or minus add antiplatelet and reassess. That can be done as an outpatient. For obstructive or heart failure and cardiac shock, we have a heart team meeting to decide between surgery or low-dose slow thrombolysis. And the slow thrombolysis is better for those with small thrombus, so less than 0.8 centimeters squared. We saw the data for that before. If they're high surgical risk, and generally for first time. Surgery more reserved for those with large thrombus, low surgical risk, those might have contraindications of thrombolysis, and where we may be unsure whether it's thrombus or something else, such as panels of vegetation. So that's mechanical valves. We'll now move on to bioprosthetic valve thrombosis. So this has gained a lot more traction recently. Here's a 63-year-old who's diabetic and had a bioprosthetic mitral valve and bypass. Post-op, they had a little bit of patient-prosthetic mismatch with slightly elevated gradient. 18 months later, they get admitted with shortness of breath and pulmonary edema. This is the transthoracic when they come into the accident and emergency room. We can see there's flow acceleration, and we see a thickening on the valve leaflets, which I think we've got a zoom of here. Okay, so we see elevated gradients, almost 3 meters per second. We see grossly thickened valve gradients and very little motion of the valve leaflets. We do a TOE, and here you can see there's thrombus has appeared just between the valve struts and the valve leaflets, both sides, and that's causing obstruction to the valve. So this is bioprosthetic valve thrombosis. And they also have a little bit of clot in the left atrial appendage. So the options are here, intravenous heparin, and they can either have a thrombolysis, valve in valve, or redo valve replacement. In this particular patient, they had IV heparin but didn't improve, and they were high risk for redo valve surgery. So we did a valve in valve. So percutaneous valve in valve, and we see that's all working well, and the gradients across that valve are normal. But let's talk about bioprosthetic valves, because traditionally we've thought about thrombosis on mechanical valves. So early after your bioprosthetic valve, there is a risk of thrombosis. And we know it's different depending on the valve. So here we have aortic valves and mitral valves. People in the gray are on anticoagulation, on the white are not on anticoagulation. And we see that if you're on anticoagulation for the first sort of 90 days or so after your procedure, you have a much lower risk of thrombosis. And this has been brought out in a Scandinavian study, which was a registry of, I can't remember the number of patients, many patients, where they looked at the effect of anticoagulation. And so here on the top left, you have stroke. Patients after surgery, first 90 days, in the white, no warfarin, in the black, warfarin. So the yellow box shows that If you're on warfarin for the first 90 days, your stroke risk is much lower. And then on the top right, you've got thromboembolic risk, so it's the same thing. And cardiovascular death is also much lower in this warfarin for the first 3 months of the bioprosthetic valve. And this is probably much all the data we have. And when you look at the guidelines, they do say you can consider anticoagulation for the first 3 months after bioprosthetic valve, and that's a class 2A recommendation. And it's been increasingly recognized not just early, but also bioprosthetic valve thrombosis can occur late. This is data from the Mayo Clinic, and they looked at all the bioprosthetic valves they explanted over a period of time. And most of these were explanted 2 years after the valve was implanted. And when they went to look at the pathology of these patients, 11% had valve thrombosis. So here you have all the different groups: aortic valve, mitral valve, tricuspid valves, which require redo surgery within 2 years, and 10%, the due cause was bioprosthetic valve thrombosis. And when they looked at predictors of why patients with bioprosthetic valves might have thrombosis, it's people with paroxysmal atrial fibrillation, and the echo indices were these three things: an increasing gradient within 5 years of more than 50%, increased cusp thickness, and abnormal mobility. And the combination of these three, A, B, and C, so increasing gradient of 50%, increased cusp thickness, abnormal mobility, had the best sensitivity and specificity for detecting bioprosthetic valve thrombosis. And that's what you saw in our case just a few minutes ago, with the thickened valve leaflets, reduced mobility, and increased gradient. And this is some of the histology, where here's a picture of the top with a clotted valve you can see in the red just there, and that's a typical valve with thickening of the valve leaflets. Whilst for PANIS is very different, the valve leaflets are often quite thin, and you have a very different echocardiographic appearance. And what do you do about these? So obviously the patient that we presented was presented as an acute pulmonary edema, but often you find these as outpatients. And the Mayo group looked at the effect of anticoagulation in bioprosthetic valves who fitted their criteria of valve thrombosis. So here you have aortic valve, a mitral valve in the middle, and tricuspid valve on the right. And this is gradient. So in blue is baseline gradient. Then in red, this is the patient when they've had their bioprosthetic thrombosis. And once they've had 3 months of anticoagulation, this is green. And what they noticed was about a 50% reduction occurred in gradient in the majority of patients, 83%. With anticoagulation. So let's move on from another type of bioprosthetic valve, so TAVI. Here's a 58-year-old who was high risk for surgical aortic valve replacement. They had a 27 millimeter TAVI valve. Pre-discharge echo, the valve velocity was normal, 1.9 meters per second, so normal. On clopidogrel was our standard therapy, but came back into hospital 3 months later, breathless. And now the gradient has gone from almost 2 meters per second to 5 meters per second. And we did a CT, and you can see on the CT, in the same place we saw in our TOE on our case, there's clot in between the valve strut and the valve leaflet. It looks almost identical to the TOE we had on the other valve thrombosis case just a few minutes ago. And we can see the clot on all three leaflets on the CT. And we can play the CT, you can see the clot on the leaflets in the dark, sort of almost black areas. So this is hypoattenuated leaflet thickening, which is the same as bioprosthetic valve thrombosis, occurs in about, I think, up to 5% of patients TAVI, initiated on a NOAC, in this case rivaroxaban, and 2 months later the valve velocity is back to normal. And there you see the repeat CT, which shows complete resolution of the valve thrombosis. So I'll conclude here that valve thrombosis is high risk, high quality imaging is essential, and it's a combination of transthoracic, transesophageal, plus or minus CT or fluoroscopy. We need to assess the size of thrombus, hemodynamic consequence, and likely etiology. We need to differentiate between obstructive and non-obstructive thrombosis, and use an individualized approach to each particular patient, whether it's optimization of anticoagulation or antiplatelet, surgery, or slow thrombolysis. Thank you very much for listening.
Thank you very much for your comprehensive and very detailed talk. Let's say here that Dr. Bhattacharya, Sanjeev, I don't know if I had ever spelled your surname correctly. Sorry about this. He's a director of the echo department in St. Bartholomew's Hospital, St. Barts in London, which is the biggest echo department in London, probably in the UK, if I'm not saying wrong. Excellent talk. Thank you very much for all the information that you gave us. I would like to point out here that this is a university hospital and a lot of young cardiologists attending this talk, not only here, but through online connection. So from your perspective, what would be your advice based only on imaging, based only on echo, not on imaging, excluding the CT, because I saw your slide that you saw the differences between pannus and thrombus. So using only echo, and according to your experience, this is the main problem more frequently to differentiate between pannus and thrombus. So what are the tips and tricks to differentiating this, apart from the leaflet thickness that you have already presented to us? And a second short question again, is AR a marker for these prosthetic valve dysfunctions or thrombosis? Thank you, Sanjeev, again.
So I think your first question was regarding thrombus versus pannus only using echo.
Exactly.
So I think there are a couple of things. So I don't think you can just use echo. I think you need to take the whole clinical scenario. So you go back to the history. Have they been compliant with anticoagulation? What is their INR? Has it been erratic? Is there a reason for thrombus to occur? And then the timing, as we, pannus is unlikely or less likely to occur within a short time of the valve being implanted, likely to occur at a later point. So I think the history is quite important. That gives you a clue. Then you need to obviously do your transthoracic echo and look at the gradients, acceleration time, etc. But it can be very difficult because sometimes on TOE, I showed you some pictures where the diagnosis is quite obvious. You see clear-cut clot on many of them. I think CT has become, you asked me not just on echo, but I think sometimes you have to do multimodality imaging. I think sometimes you do need CT to help you. I think most of the time, though, it can be sorted out with echo, because most of the time, examples I saw were clear-cut thrombus. And your second question was about aortic regurgitation, is that right?
Aortic regurgitation, right? If it is a marker of, if it is a sign, a marker that can help us to differentiate, to assess valve dysfunction / valve thrombosis.
So if you have an occluded valve, depending on how it's occluded, you can get aortic regurgitation. So most of them are stenotic, and you'll get increased gradients. But if you do get aortic regurgitation, you can get clot and prevents the closing mechanism, you can get aortic regurgitation. So yeah, if you do see that, you have to look at the valve in detail.
Thank you very much. So is there anyone from the audience that you'd like to ask to have a question?
Thank you, Sanjeev, for your excellent talk. I have to add a more question. Do you think that pannus should be just a thickening of the prosthetic valve, and the thrombus is a large mass and not just thickening? Because from your experience, do you think that pannus should express as a mass or just thickening of the prosthetic valve?
Usually it's just thickening, and will come in from the sewing ring, whilst thrombus is often a mass, and normally most of the cases of valve thrombosis that we've seen have been, if you measure them, it's a centimeter or more. So there's often quite a difference. The difficulty is when you have someone with a history where you suspect thrombosis because the INR is low, etc., and you can't see a thrombus. And sometimes, even despite spending a long time doing TOEs, trying to get every angle, and if not be able to see thrombus, then we've seen it on the CT. So I think, in general, yes, that thrombus generally is larger, it's sort of more occlusive. And most of the time, the diagnosis is straightforward based on the transthoracic and TOE. But I think sometimes we have to use other modalities.
Okay. Dr. Dimitroglou.
So there is one question for you, Sanjeev, from the audience.
Hello, excellent talk. The microphone. Do you hear me? Okay.
Yep, I can hear you.
Okay, excellent talk. Just a quick question, since low stroke volume and cardiac output is a risk. Low cardiac output, low stroke volume is a risk factor for valve thrombosis. And it's also known that in patients with low cardiac output, gradients are usually low, so they underestimate the stenosis. So in these patients, some tips and tricks, except maybe acceleration type from transthoracic echo. In transesophageal, maybe we have some views, but we need to be ready to recognize a potential thrombosis from transthoracic echo before we do the TOE. So any tips from the TTE, transthoracic?
Yeah. So that's exactly right. If you've got low cardiac output, your gradients will be lower than you expect. And you can get a lot from the transthoracic. So you saw my first example. This was a patient where the RV had become dilated and dyskinetic, which wasn't like that before, due to the obstruction of the valve. So that gives you a clue that something is not right with this patient. The RV is dilated, dyskinetic, etc. And then you can often see the disc motion of the leaflet motion from the transthoracic if you do it well. You saw my thrombolysis case. Prior to thrombolysis, there's no motion. And then after slow thrombolysis, you can see the disc opening closing normally. So I think you can get a lot of information from the transthoracic. And you can also look at the colour flow. So you can see, is there an absence of colour flow through one part of the valves? So all the things you can see on the TOE, you can also see, you can get a lot of information from the transthoracic if done carefully and well.
Use something. You have already presented a paper on biologic valve thrombosis. I think that it's a rare condition. Which is the mechanism of biologic valve thrombosis? Because we know the mechanical thrombosis is due to rheology or due to, what do you think?
Yeah, so this was, I mean, it's interesting. I saw the paper from Mayo, and prior to that, I'd only had one case I'd ever seen. And now we identify a lot more of it. So I think it's a couple of things, because it depends on which side of the heart you're on. So it's more likely to come on the right side if you've got bioprosthetic valves there. But also people with atrial fibrillation. In fact, nearly all the cases that I think we probably underestimate the frequency of atrial fibrillation, because atrial fibrillation can be paroxysmal, and we may not detect it. So we might think our patients is in the sinus, but then they may have paroxysms of atrial fibrillation, which predisposes them to clots on their valve due to the change in flow in the atrium, etc. And that Mayo paper showed that was one of the highest risk factors for developing valve thrombosis, bioprosthetic valve thrombosis.
I have no experience on such patients with biologic valve thrombosis. Do you think that the inflammation should be a mechanism? Maybe it's a part of systematic disease?
I think it probably, I think you're right. I think it probably is, because when we get these patients with bioprosthetic valve thrombosis and we've managed to treat them by whatever way, whether it's resolved with anticoagulation or they've had redo surgery, I think there's no data for this, but we tend to keep them on anticoagulation for the rest of their lives, because there's obviously been an underlying cause of this. And whether that's inflammation or disruption of the endothelium I don't think anybody really knows, but if they've had one, we tend to keep them on anticoagulation forever.
Thank you very much. So is there any other question from the audience, please? Sanjeev, thank you very much for one more time for your great talk. and we hope to see you again in the future in one of any other conferences. Thank you very much.
See you. Thank you very much.
Thank you. Bye.
Bye.
Bye.